and now, Tadey, are you somewhere? Okay.
Yes. Hello.
Good morning, Tadey, and so sorry. Maybe it was a misunderstanding about the hour, but it's great that you are with us today and with a very nice talk. I give now the floor to my colleague, Laura Damian, to present you, and then we are waiting to hear you. Thank you.
Thank you. Thank you.
Hello. Very nice to have you here, Professor Tadey Avcin. Professor Tadey Avcin. Avcin is the president of the Education and Training Committee of PRES and past president of the Standing Committee for Pediatric Rheumatology of EULAR. And he's well known for his research activity focused on systemic rheumatic diseases in children and diseases of immune dysregulation. So it's a pleasure to have you here, and the floor is yours.
Thank you very much. Thank you for the kind invitation. It's a pleasure to be here. First, I would like to apologize for mixing the Romanian time and Central European time. It would not happen if I would be in Romania. I will share my screen, my presentation. Can you please just confirm that the screen is shared?
Yes, we are seeing your screen.
Okay, perfect. Thank you very much. So my talk will focus on multi-system inflammatory syndrome in children, which is a multi-system inflammatory condition linked with SARS-CoV-2 infection. Slovenia, my country, was pretty much affected with COVID-19, with several cases, particularly in the second wave. And the first patient with MIS-C we saw in the middle of September, and the most busy months were November and December. Now the situation is slowly getting better, and in my presentation, I would like to somehow share with you some recent advances in this field and some of our local clinical experiences, let's say, a view from a clinical practitioner following these patients. So we always try to look at the biology behind the disease to diagnose as early as possible and treat as targeted as possible given the biology of the disease. I will start my presentation with a typical case that we saw, let's say, in the last 4 months. The case is a 10-year-old boy who was admitted to the pediatric infectious disease ward on a 4th day of fever up to 39 degrees centigrade with abdominal pain and mild diarrhea for 2 days and red eyes and skin rash for 1 day. Usually parents brought children around 4 or 5 days, and it is quite important to somehow rapidly diagnose these patients. So this patient had mild conjunctivitis. We have seen also much more severe conjunctivitis in these patients. This patient had rash in his axillary area and trunk, and some palmar erythema that was most pronounced on fingertips. And on laboratory examination, he had high inflammatory markers, leukopenia, anemia, low platelets. Quite typically, these patients have hyponatremia, probably due to impairment of sodium-potassium pump, mildly elevated liver enzymes, signs of coagulation disturbance, and high level of troponin and pro-BNP levels. So this patient had some investigations, including the echocardiography, that showed signs of myocardial injury with diminished global longitudinal strain, which is seen like this on ultrasound examination with these whitish areas or mild red colors. Normal is this dark red color, approximately -20 is normal value of this contractile global longitudinal strain, and this patient had moderate impairment of myocardial function. So let me move to the back to the presentation. This multi-system inflammatory condition, clinically, it really looks as a combination of inflammatory systemic conditions that we are aware of. It looks like a severe Kawasaki disease. In some patients, it looks like a typical macrophage activation syndrome. In some patients, it looks like a toxic shock syndrome. It's like a mix-up of all the systemic inflammatory conditions that we are aware of. Terminology that you might come across, in UK, they use the term pediatric inflammatory multisystem syndrome, temporarily associated with SARS-CoV-2, or acronym PIMS-DS. But now worldwide, most common is MIS-C terminology. MIS-C is used by WHO and CDC, and it is not just a terminological distinction. In PIMS-DS, in PIMS-DS and MIS-C, you have to have fever and elevated inflammatory markers and signs of multi-system inflammatory involvement. But in PIMS-C, the definition is a little bit broader. It requires positive or negative PCR test, while in CDC definition, it is a requirement for positive PCR or serology, or confirmed, let's say, COVID-19 exposure within the past 4 weeks. So in our opinion, we use MIS-C definition. It is more specific, and all our patients had confirmed COVID-19 infection. Epidemiology of MIS-C. So these are the latest available data from United States in March 2021. They have in their database 2,617 MIS-C cases and 33 deaths because of MIS-C. This condition is more prevalent in males, and it is somehow reported in US that this condition is less likely occurring in white population, that it is more common in Hispanic and Black. In our local experience, and I would be pleased to discuss your local Romanian experience, this is not the case that the white Caucasian population is somehow spared. Our population is 100% Caucasian of MIS-C patients. We had 30 cases up to March 2021, and calculated comparing to the US numbers, we have approximately double the numbers of MIS-C cases per population, per country population. We tried to calculate epidemiology of MIS-C to some more, let's say, firm markers of epidemiological markers. And our estimate is that we have 2.5 MIS-C cases per 1,000 hospitalized COVID-19 patients in Slovenia, and 1 MIS-C case per 500 confirmed SARS-CoV-2 infections in patients below 25 years. We also have more frequent MIS-C in males, and as I said, ethnicity is 100% Caucasian. Biology behind this disease. So I included just one slide to somehow remind how strange is SARS-CoV-2 virus. It somehow attacks these early components of our inflammatory response. So innate immune cells with formation of neutrophil extracellular traps because of activated neutrophils, and cytokine storm because of activated macrophages and monocytes. It attacks endothelium, and it attacks, let's say, coagulation system with thrombotic complications. And these somehow early innate immune systems are involved also somehow in MIS-C. This is the time course of MIS-C cases comparing to the cases of COVID-19. So the blue line is the COVID-19 cases, and MIS-C cases are this red line. You can see that somehow MIS-C cases are following the epidemiology of SARS-CoV-2 cases. there is approximately 4-week delay of presentation of MIS-C compared to COVID-19. This is the time course of MIS-C cases. Cases with MIS-C, when they present to the clinic, they do not have positive PCR. At least in our cohort, none of them had positive PCR at admission. But 1/4 to 1/3 of patients had positive PCR approximately 4 weeks before. So when they presented with some symptoms of COVID-19. So we can say that MIS-C is not mediated by direct viral invasion, but coincides with the development of acquired immune response to SARS-CoV-2. With the MIS-C pathophysiology, we are more and more aware that it is somehow interplay between the innate and adaptive immune system. We do not know exactly, but I would like to highlight some of the things that we already somehow know and are trying to solve. The first thing is the activation of the innate immune system. SARS-CoV-2 activates NLRP3 inflammasome and induces secretion of inflammatory cytokines, IL-1, beta, and IL-18. And these are data from children with MIS-C. T1 is an acute stage of MIS-C. You can see that patients with MIS-C in acute stage, when they had diagnosis established, they had activated neutrophils, they had activated macrophages, and this is a marker of this is the most active population of neutrophils, which is very elevated. The second somehow thing that we know about MIS-C is that children with MIS-C have high level of antibodies against SARS-CoV-2 already at the time when they present with this systemic inflammation. So already at admission, they would have high level of anti-SARS-CoV-2 antibodies. These are data from published in Nature Medicine, showing a high level of antibodies against nucleocapsid, against RBD and spike protein, including IgM and IgG, and these are data from our cohort. And these numbers are compared to healthy children who got COVID-19 and healthy adults who got COVID-19. So these are not children who were not in contact with COVID-19. And children with MIS-C had even higher anti-SARS-CoV-2 antibodies than children and healthy adults after COVID-19 infection. It appears that this activated innate immunity in patients with MIS-C somehow disturbs also the adaptive immune response. You can see T cell and B cell lymphopenia and activated and proliferative phenotype of T cells. And somehow the resolution of MIS-C is associated with an increase in Tregs. And I will show you this on this slide. These are decreased T cells at the acute stage. These are decreased B cells at the acute stage, and these are regulatory T cells at acute stage decrease, and then increase with the resolution of MIS-C. What is striking with the MIS-C pathophysiology is that antibodies to SARS-CoV-2 might actually enhance a host inflammatory response. And actually anti-spike antibodies against SARS-CoV-2 could even aggravate and exaggerate inflammation in human macrophages. I will show you just one slide of study that is showing this extremely high IL-1 beta, IL-6, TNF-alpha excretion when there was the combined spike protein serum and anti-SARS-CoV-2 immunoglobulins. Why is this so concerning? Because we do not know whether we should vaccinate children with MIS-C. If we would vaccinate them, they would have even higher level of anti-SARS-CoV-2 immunoglobulins, and it's somehow the decision what is better. Probably to vaccinate, but we are somehow concerned that this could induce the macrophage hyperinflammation response. We will see in the future. So regarding the early recognition, which we think is the most important for the long-term outcome of these patients, this is a figure showing the age distribution of patients with MIS-C compared to the Kawasaki disease patients. You can see that Kawasaki disease patients are younger, while MIS-C cases are widely distributed. And our youngest patients was 1 year old and the oldest 18. So it's really kind of a equal distribution according to different ages, maybe a little bit more in older ages. These are pooled data for clinical manifestations. And in this figure, I try to highlight the presenting symptoms. I think that the early diagnosis is the most important. Fever is by definition present in all patients. Quite frequent are gastrointestinal symptoms, and gastrointestinal symptoms seem to be early. Patients complain of abdominal pain. They have diarrhea, but diarrhea is usually not severe watery diarrhea. They have a few stools per day. Some patients have vomiting, and rash appears a little bit later. Very polymorphic, different. We have seen different rashes. Conjunctivitis, mucocutaneous involvement is also somehow frequent, and respiratory tract symptoms very rarely. During the course of the disease, cardiovascular dysfunction is present in approximately 80% of patients. In our cohort, even more, 90% of patients have some myocardial involvement, and respiratory dysfunction in less than 10% of patients. In this figure, you can see our data. These are the number of patients, and this is the temporary manifestation. We do believe that the dynamics of clinical and laboratory features is very important for early diagnosis and for somehow following the disease. Fever is present from the very beginning, and these gastrointestinal symptoms are also present quite early. Usually the patients come to the clinic around 4th to 5th day, when they also got these mucocutaneous clinical signs. And I will show you some pictures of our patients with a rash on the back. One patient who was treated in intensive care. This was a patient who actually presented quite late. He was admitted to another hospital, and because of this, he came to at 7th day of the disease, and that's why he had more severe complications. You can see this rash on the trunk all over his body. And several children presented with this palmar erythema or palmar rash that was more or less severe. This is one of the more severe rashes, and this is, I would say, moderate severity of this palmar rash. For cardiovascular involvement, I said they are present approximately in 80% of patients. Quite rarely aneurysms, coronary artery aneurysms, not so frequent, much more frequent myocardial dysfunction. So it's actually myocardial impairment, much more frequent than middle-sized artery vasculitis as seen in Kawasaki disease. And this can be also monitored in laboratory with elevated troponin and BNP. From non-cardiovascular involvement, I already mentioned GI involvement, but these patients can have really multi-systemic involvement. The longer you will wait with the disease diagnosis, the more organ systems will be involved. We have seen some patients with pancreatitis. Patients can develop some renal involvement, neurologic involvement, particularly if the diagnosis is lately established. Some colleagues in India even reported that neurological impairment in their cohort was present in up to 60% of patients. Hematological involvement, I will show in the laboratory results. They reported in up to 7% of patients with venous thromboembolism. We had no patient with thromboembolism, but I will show you some of our anticoagulation treatment guidance. Syndrome clusters, according to the age groups in MIS-C, it appears that children with a younger age, less than 5 years old, so these preschool children, they have slightly different immune system, slightly different systemic inflammatory response. They have a little bit more mucocutaneous symptoms, a little bit less gastrointestinal, so a little bit more looking like Kawasaki disease patients, but let's say these school-age children, almost all these patients had myocarditis and approximately 20% neurological impairment. Regarding the laboratory evaluation, so one is to establish systemic inflammation, the involvement of macrophages with high ferritin level, to establish the different organ involvement. We include also electrolytes because, as I said, most of the patients had also hyponatremia at presentation, involvement of myocardium and coagulation, which I think is quite important in this condition. For other laboratory evaluations, all our patients had positive serology. So in our cohort, we established diagnosis with MIS-C if they have positive serology, and other studies according to, let's say, the clinical condition. With laboratory markers, you would see elevated inflammatory markers, lymphopenia, lowish platelets at the beginning of the disease, elevated D-dimer, and increased heart enzymes. I would like to show you the same as for the dynamics of clinical presentations, also the dynamics of laboratory parameters over time. CRP and troponin levels have almost similar curve. After you start treatment, it is like with steroids, it is like that the inflammation is melting down. It's melting down, it's not in one day, but it's usually in 10 to 14 days after starting steroids, the CRP and troponin level would drop down. Liver enzymes stay mildly elevated, but platelet count usually follows like a G-shaped curve. With the peak of the MIS-C inflammation, the platelet count would be lowish, and then after starting treatment, they would start to increase, pretty much the same pattern with Kawasaki disease, but Kawasaki disease at acute stage usually do not have thrombocytopenia. So this is the difference with Kawasaki disease. For serum cytokine levels in MIS-C, you would see quite high IL-6 and IL-10 levels, and comparing to HLH, macrophage activation syndrome, these patients had also elevated ferritin and IL-18 and CXCL9, which is one of the markers for activated macrophages. Usually these levels are not so high as, let's say, in full-blown HLH, but patients with MIS-C definitely show signs of macrophage activation. One of our patients had really clinical features of HLH, and we performed bone marrow analysis. You can see here the macrophage with signs of erythrophagocytosis. And what is striking and was actually reported in severe COVID-19 cases is that these patients have these vacuoles in macrophages. Imaging and consultation. So all patients undergo chest X-ray, abdominal ultrasound, echocardiography, and consultation of different specialists. The most striking is this myocardial dysfunction with decreased global longitudinal strain. So the lowest value, the worse. And patients with MIS-C compared to normal and also Kawasaki disease patients have significantly impaired this global longitudinal strain, which is also somehow showed in this figure that patients with MIS-C with myocardial injury have the most impaired. When we compare MIS-C with Kawasaki disease, MIS-C has a wider disease spectrum. Patients have, I showed you these different ages of MIS-C. MIS-C is not more prevalent in Asian population, but I would say African, Hispanic, but also white Caucasian. It has greater elevation on inflammatory markers and myocardial injury, and very rarely coronary artery aneurysms are seen in Kawasaki disease patients. Treatment guidance and disease course. So the goal of treatment is to decrease systemic inflammation as soon as possible. As I I showed you one patient from intensive care who was diagnosed on 7th, 8th day. And in our experience, the period from 5 to 8th day is crucial. If you will establish the diagnosis early and start treatment early, the inflammation will really melt down like a melting snow. If the patient would continue to have this systemic inflammation, would be unrecognized, for example, on some surgery ward, the myocardial inflammation would continue. We had one patient who had severe myocardial inflammation and got malignant rhythm disturbance, was reanimated. And this was the only patient who had ECMO treatment, but after pulse, methylprednisolone and Anakindra treatment actually had a really good outcome. But if this patient, for example, would not be recognized, the outcome could be also very bad. Really, I would say be cautious. 5th to 8th day are somehow crucial for early diagnosis. After diagnosis, in addition to decreasing systemic inflammation, restoring organ function. First-line treatment is IVIG. We usually give IVIG immediately when we suspect MIS-C. There are some differential diagnoses. We had patients with acute gastroenteritis who presented like a MIS-C mimic. Even one autoinflammatory disease, TRAPS patients who presented as a MIS-C mimic. So IVIG immediately after we got results, and if there are signs of myocardial impairment, we would have immediately echocardiography performed and methylprednisolone administration at the dose of 1 to 2 milligrams per kilo. The severe life-threatening disease would got pulse methylprednisolone 10 to 30 milligrams per kilo for 3 days, or until they would be clinically stable, and then followed by methylprednisolone IV. Usually we are able to stop methylprednisolone. So with tapering, we are usually able to stop in approximately 1 month or up to 6 weeks. And we had 3 patients that were refractory to this treatment and got Anakindra treatment. And 1 patient got Anakindra because of pancreatitis, and we had to decrease steroids dose quite quickly. Antiplatelet anticoagulation therapy are, I think, very important in preventing complications. So all our patients would got aspirin unless they have some contraindication. We usually give aspirin in anti-aggregation doses. And anticoagulation in ACR guidelines, it is recommended that anticoagulation would be given only in patients with coronary artery aneurysms, documented thrombosis, or left ventricular dysfunction. This is not in line with ISTH recommendations, where they somehow treat with anticoagulants children with MIS-C the same as hospitalized children for COVID-19 acute infection. And our experience that was recently published in Arthritis and Rheumatology is pretty much the same, that we do not give anticoagulation to patients with complication, but we give prophylactic anticoagulation with low molecular weight heparin in all children with MIS-C in the absence of contraindications. So 70% of our children with MIS-C got anticoagulation therapy. We usually give with anticoagulation with the target anti-10A level 0.2 to 0.3. And if they have extremely elevated D-dimer, we intensify this anticoagulation therapy. And up to now, we had no cases of thrombosis, and we usually stop anticoagulation 1 to 2 weeks after discharge from the hospital. So this was also the treatment that was given to our patient that I presented at the beginning, and you can see in this slide significantly improved echocardial signs of global longitudinal strain. The outcome, these are also pooled data. In our cohort, less ventilation support, only 10% of patients needed ventilation support. One of our patients, which is required ECMO treatment, we had no mortality. And I already mentioned that early diagnosis is probably crucial for good long-term outcome. To conclude, I would like to highlight that MIS-C is the severe phenotype of the spectrum of inflammatory and autoimmune manifestations associated with SARS-CoV-2. One of the key messages is that MIS-C is frequent also in white Caucasian population. It has a wide spectrum of clinical presentations. And in our experience, really the early diagnosis is crucial, and probably most of the cases are diagnosed around 5 days after the fever onset. And multidisciplinary team approach is somehow crucial. We established multidisciplinary consilium once weekly, where we meet with cardiologists, infectious disease specialists, rheumatologists, hematologists, and discuss what would be the best treatment for these patients. And with this, I would like to thank all my colleagues that are involved in treatment of MIS-C patients, hematologists, infectologists, rheumatologists, our unit, and infectious disease. Thank you very much.
Thank you very much. Thank you very much for this excellent talk. Thank you for this excellent talk. I was wondering, how is, if may I ask, how is procalcitonin in this case? How are the infections? Yes.
Procalcitonin is high because when they present, they had really signs of severe systemic inflammation. So all the markers of systemic inflammation are high at admission. At the beginning, we consider whether this could be sepsis or some other systemic inflammatory condition. Usually a distinguishing feature is that these patients have quite early also this elevated troponin and pro-BNP values and high D-dimer level. For troponin, when the troponin starts to rise, you can expect that it will rise in exponential curve. So maybe if a patient had in the morning slightly elevated troponin, in the evening, this troponin could be even 2 or 4 times higher. So do not wait for the next day for echocardiography or starting treatment. So this is one of the messages that we are trying to convey to our attending and physicians staying overnight, that these patients needs to be evaluated as soon as possible and treatment started as soon as possible.
Thank you.
Thank you, Tadey. It was excellent, and it's very important for us to know about this disease. I understand that it's described special with SARS-CoV-2 infection. Did you see similar things with other infection diseases?
So similar is Kawasaki disease, but the link with the infectious disease is not so, Kawasaki disease was linked, 50% of Kawasaki disease patients had some preceding infection that could act as a super antigen activating this systemic inflammatory response. But SARS-CoV-2 is really unusual virus, that it is the first infection that is so clearly linked with systemic inflammatory response. I would say one resemblance could be acute rheumatic fever with, let's say, the streptococcus inducing inflammatory response, but not like SARS-CoV-2. So this is actually the first virus that would induce such a wide spectrum of multisystemic inflammatory conditions. And it is probably really interlinked with activated innate immunity, significant antibody response that we see in children with high levels of anti-SARS-CoV-2 antibodies and somehow dysregulated T regulatory cells in these MIS-C patients. It's really specific for the pediatric population and is rarely reported in adults as a MIS-A, multisystem inflammatory syndrome in adults.
In adults, okay. And what about, maybe we are lucky that you are a little bit late now in the program, because our infectious disease specialists are with us, and also they will talk a little bit later about the vaccination, and maybe they want to intervene and to say something about this. We didn't see this disease, and I can't remember someone from the pediatric clinic to ask me something about this. But Professor Lupce is online, and maybe she wants to comment a little bit. She's the head of the infectious disease in Cluj. Mihaela, are you
Yes,
somewhere?
Here, yes.
Okay.
Okay, so there was a very interesting presentation, and actually, even if this syndrome, it's a rare syndrome in children, in Cluj, we had only one case during summer, last summer, and the outcome was good. In that period, we didn't have Anakindra for treatment, so we didn't use Kineret, but we used corticosteroids in high doses. And what I heard now from you is that Anakindra was useful for your cases. So I want to ask you which dose of Anakindra did you use? But before this, I want to mention that in Cluj, we had only one case, who was probable MIC's case, but for Romania, I checked and I found on ECDC site that we are one of the countries with a lot of cases reported, because all these cases should be reported also in Romania, like in other countries. And I saw that Romania is a country with a high number of cases, and all these cases were from the south part of the country, so near Bucharest. I don't know if there is an explanation or not why these cases are more in the south part. I don't know. We are aware about the possible systemic inflammation in children, so we check for every case this situation, but we had only one. In the south part, it seems that the number of cases is much higher. I come back to my question. If you can say me exactly the dose of Anakindra you use in children.
So regarding the dose of Anakindra, the ACR recommendation states that usually the children require 4 milligrams per kilo. Our practice is that, in 3 children, we used Anakindra, and we usually start Anakindra like this, that if the patient is in intensive care, we would give first, on the same day, 1 milligram per kilo as a first dose. After 12 hours, we would re-evaluate, and usually we would give the second 1 milligram per kilo. So the first day we would usually give 2 milligrams per kilo, and in our children, it was enough. So we didn't give more than 2 milligrams per kilo, but in the literature, it is reported that these patients require higher doses of Anakindra. I don't know whether this was because we gave this early and combined with pulse methylprednisolone, but be aware that these patients might need higher dose of Anakindra. And usually when the patient stabilizes, we reduce Anakindra to 1 milligram per kilo, or we round up to 100 milligrams, not to throw away actually the drug that is potential. So we usually give 1 ampule of Anakindra to patient that would be, let's say, 60 or 70 kilos weight. Regarding the cases, I can share with you our experience in the first way, where we had no MIS-C patient. And we also, thought, oh yeah, this is a condition that happens in Hispanic and Black population reported. But during the second wave, we were really strongly hit. Maybe Slovenia was, kind of an area that really, we estimate that approximately 10% of our population got COVID-19 infection. And it came in at the end of November, at the end of October, it came like a tornado. So we had 4 cases in 1 week, and in November, 10 cases, and in December, 10 cases. So this was actually, we were Miss C ward for 2.5 months. And after, let's say, 10, 15 cases, you see the pattern. You see the pattern in these patients. That's why at the beginning, we were not so cautious about this early diagnosis. That's why I'm trying to share our experience on the dynamics of the clinical manifestations and what are kind of early warning signs.
Yes, that's true. Thank you very much.
Okay.
Another question. Do you think that tocilizumab could be an option?
Yeah, well, tocilizumab was reported. We used only Anakindra, and we considered to use one in one young patients that had more like a Kawasaki disease features with IL-6, but then we actually decided to give Anakindra. So I have no personal experience with tocilizumab. It was reported in the literature. Given the disease pathophysiology, I would say that probably both drugs are successful, but most of the centers are preferring Anakindra as a first-line biologic.
Yes, we also prefer this for adults.
Yeah.
Okay, thank you very much.
And Tadey, a last question. What about vaccination? Which is the general attitude with vaccination in children? And what are you, I understand that for these children, vaccination can be a problem because the high titer of antibodies.
So regarding the vaccination, the situation in Slovenia is like this, that we are vaccinating children above 16 years old with that are specific, let's say, chronic risk, that they have specific risk. So children with immunosuppressive treatment, with biologics and so on. For children with MIS-C, it's a $1 million question. It's really, this is one of my biggest concerns. So if they would got another contact with the wild virus in their school, I'm concerned that they would have, again, this hyperinflammatory response. If we would vaccinate them, they would have high antibody levels, and again, there could be some risk for systemic inflammatory response. So let's say, we did not vaccinate any child with MIS-C. We do see that their antibody levels are falling quite rapidly, the same as for the healthy population. So the level of antibodies are really dropping very rapidly. And our plan now is that to follow these children, so the whole cohort is quite, let's say, stringently followed. We are planning to perform after 6 months the serology evaluation, and probably we will be prone to vaccinate them after they will lose their anti-SARS-CoV-2 antibodies. So, and we are trying to establish some laboratory functional tests to see if they have macrophages that would respond to SARS-CoV-2 protein stimulation. So we are just now kind of establishing a study protocol with seahorse, these laboratory parameters to check the macrophage metabolism in MIS-C patients comparing to, let's say, healthy children after COVID-19.
Okay, thank you, Tadey. Thank you to be with us. Sorry for the misunderstanding, and hope that next time you will be in Cluj.
Thank you very much.
Great. Thank you.
Bye-bye.
Avem nevoie doar de 2 minute ca să schimbăm din nou setup-ul și speakerii și moderatorii și revenim cu ultima sesiune, cea de vaccinare. Mulțumesc frumos!